The role of genetics in IPF has evolved quite a bit in this decade. We've learned a lot about many different genes from different studies, different study designs. These genetic findings have not yet made their way into the majority of clinical practice. I will talk about that. I want to give you a little bit of background on what we know about the genetics of IPF. Some genes that have abnormal variants are associated with a very high risk of developing lung disease. These are very uncommon in the population. These are genes such as surfactant proteins A and C, TERK mutations and TERT mutations, as well as RTL1 and PARN mutations. All of those 4 genes are involved in telomere length, and we know that telomere shortening is associated with cellular senescence and aging, predisposing the lung to injury and abnormal healing. On the other hand, there are a whole lot of genes that are actually quite common, or fairly common, and associated with IPF risk, but the penetrance is low, meaning that most people with that genetic variant will not develop IPF, fortunately. And there are certain genes such as TOLLIP, DSP, a whole variety that have been found in genome-wide association studies that fall into that category. And then in between those rare, powerful, and common weak genes, there's one called MUC5B, MUC5B, which is highly prevalent. It's about 30 to 40% of IPF patients will have a variant in the promoter SNP of MUC5B. But also 10% of unaffected people, 10% of the population will also have this variant. Quite prevalent, but less penetrant and falling in between. If you have the variant, the risk can be high. We've identified many in the community, many genes associated with IPF risk, including genes involving interleukins, cell adhesion molecules, airway and host defense, as I mentioned, telomerase, genes responsible for maintaining telomerase length, and many others. Interestingly, some of these variants are also associated with increased mortality. One of them, the MUC5B variant, actually, if you have the variant and you have IPF, you end up having better survival than those who don't have the variant. So it's a little bit paradoxical, so that the variant increases the risk of IPF, but if you have IPF, the variance decreases your risk of dying, or at least your progression to death occurs more slowly. And we certainly see that in people who are homozygous for the MUC5B minor allele, which is T, but the heterogeneous, heterozygote, the GT genotype, much more prevalent and still better outcomes than the GG genotype. I mentioned short telomeres. These are important. Short telomeres can be detected in peripheral blood mononuclear cells, not clinically, but in the research setting, and of course in alveolar epithelial cells and other lung cells. Shortened telomeres, sometimes related to mutations in those telomerase genes, those short telomeres are associated with worse outcomes. And I will say that while we don't generally test for short telomeres or telomerase gene mutations in the clinical setting, when patients seem to be high risk, for example, as you saw in the case, someone with lung disease, family history, premature graying, thrombocytopenia, those things all point to short telomeres. That's what that case was about. And the lung transplant docs get concerned about telomerase mutations and get concerned about short telomeres because there's an increased risk of acute and chronic kidney disease and other complications, including bone marrow suppression after transplant. So clinically, some of the transplant docs are now asking for data on genotyping or sequencing, rather, of some of these genes. One very interesting, and this is like a glimpse of the future, I think, is a potential for what we call precision medicine in IPF. You may be familiar with the Panther IPF trial, and specifically I want to focus on the N-Acetylcysteine or NAC treatment arm compared to placebo. So these were adults with IPF, FVC over 50% predicted, randomized to NAC or placebo over a year. And that study, which was published a few years back now, showed really no effect of NAC on lung function decline, and really no consistent signal of a benefit. However, in a post hoc analysis, when some savvy investigators looked at this effect of NAC, not just on lung function, but on survival, what they found is that variants in the TOLLIP gene, T-O-L-L-I-P, TOLLIP, variants in TOLLIP were associated with treatment effect. so that those who had the CC genotype, even though there's only a few of these folks, people with the CC genotype actually had a survival benefit from NAC, whereas those with other genotypes, like the CT genotype, really NAC didn't seem to have an effect. So this is a glimpse at whether or not we could use NAC, or in the future maybe other therapies, in people who we select based on their genotype. Now this needs to be confirmed in future studies, and I do hope there's another trial investigating this, but this is very promising as potentially a role for NAC, although currently the recommendations are not to use NAC to treat IPF. Clinically, let's talk about the clinical, the patient in front of you, who gets genetic testing. My experience, and others have written about this as well, is that there is no role for routine genetic testing in patients with IPF. When a patient has a strong family history, or they have evidence of short telomeres, and these are the clinical features you saw in the case, premature graying, thrombocytopenia, sometimes cirrhosis even, family history of lung disease. Those are settings where I will consider sending the patient, if they're interested, to a clinical geneticist and genetic counselor to see if genetic testing may be helpful. In most cases, in my experience, this doesn't change treatment, with that one exception of transplant. That is, the short telomeres or telomerase gene mutations. Transplant folks get a little nervous. But in most cases, this isn't going to change my therapeutic approach. In the research setting, whole exome sequencing, whole genome sequencing, sequencing of whole families, there's a lot of exciting stuff in the pipeline that's a few years from now. I want to shift from genetics to talk about a couple other factors related to ILD. And these are things that, on the diagnostic front, on the management front, that are often glossed over a little bit. The environment that our patients live in is often a big factor in their lung disease. For example, if we've diagnosed a patient with hypersensitivity pneumonitis, then we know we have to remediate the mold, get rid of the bird. Or if we have a patient with a pneumoconiosis like asbestosis or silicosis, usually they're already out of the exposure, but if not, we need to move them out of the exposure. But really, in a broad sense, we know that inhalational exposures are harmful and can cause lung fibrosis in susceptible patients. And hypersensitivity pneumonitis falls on a spectrum with, I think, IPF and idiopathic NSIP. We biopsy these folks and we see all different patterns. So for my patients with IPF, even if they don't have HP, even if they don't have an occupational lung disease, I advise them to avoid inhalational exposures, dusts, fumes, vapors, gases, mold. I say anything you can smell. If you can smell paint fumes, get away. Not that we know that works, but safety in the environment is important. I tell my patients, only breathe air. And finally, I want to mention lifestyle and health maintenance. If you're a pulmonologist or pulmonary practitioner or NP, taking care of these patients, as you know, we always focus so much on the pulmonary aspects. Their primary care providers will focus on their other healthcare needs, but I think these things are really important. Smoking cessation, critical. I will say most patients I see with IPF, if they smoke, they quit long ago, but sometimes they're still smoking. Obviously critical. Talking to patients about travel, traveling with oxygen on an airplane, traveling on long car trips with oxygen, going on a cruise, traveling to where their destination is at altitude. There is guidance in literature and even from the Pulmonary Fibrosis Foundation on safe travel. Exercise is important for patients with lung disease. If it needed, we give them oxygen so that they can be as active as possible. Referral to pulmonary rehabilitation, really important lifestyle, really important intervention that can improve your patient's lifestyle and quality of life. And of course, achieving a healthy weight, particularly if they need to be referred for lung transplantation and age-appropriate vaccination.